Start our recording. It's great to see folks for we are at the very end of February. So the Child Outcomes Accountability Team, the end of February. Hi, Brina. You found us.
I'm so sorry. This is a COVID phenomenon with Brina. 5 minutes late to every meeting. Never before. I was always on time.
If you're only 5 minutes late, we can handle that. Just welcoming folks and getting going. Dora, I'm going to hand off entry to you if you can do that. And today's meeting is really, in some ways, a follow-up to last month where we were talking about universal screening. And we're really talking about the relationship between kind of the medical and pediatric world and early childhood world, which, I think Brina will give us the sense of how we're doing in Vermont, both with child outcomes as well as the relationships that hopefully help us get there. But I did want to get us started. If folks want to do, I think we're a pretty familiar crowd, but if you want to do intros in the chat bar, and I'm going to share my screen as well to review some of the stuff that we did last month, just to frame and refresh our memories, because, hey, it was last month. And then I'm going to hand it over to Brina. How's that sound? Okay, great. So I need to bring up the chat bar so I can see that and share my screen. All right, there we go. So last month, we reviewed the importance of screening for social determinants of health and child development current efforts in Vermont. We built a vision of successful universal screening initiatives, which I'll share with you in a minute, that edited version. And through our discussion, we identified opportunities to expand alignment and integration across settings to increase universal screening. So I want to share the vision with you. Here we go. And thanks to Scott and others who kind of helped with some editing following the meeting. So our hope in creating this vision is, it was both a taking stock of where we are in terms of universal screening, but also where do we want to be. So this is still, we can still work on this, but our collective vision around characteristics of successful screening. Providers and practitioners working with children and families increasingly recognize their role in identifying and addressing families' social and behavioral health needs, such as food, housing, adult mental health, etc. It's a long list. In addition to the efforts for earlier identification of a child's developmental delays and referral for early intervention, relationships matter. When done well, families have a relationship with the provider and participate in the process, followed by professional guidance and referral to connect with the supports they need. Screening is done with respect and with cultural humility. When screening practices are normalized and universal, less people fall through the cracks, between the cracks, bias is limited, and the conversations are destigmatized. Screening is an integrated part of the workflow, whether in a medical practice, childcare, school, home, or other setting, and is routinely administered. 3 under 3 for child developmental screening and for social determinants. Providers and practitioners share responsibility and are thoughtfully coordinated, able to share data and use screening and follow-up as a tool to support child and family outcomes. So as you listen to that vision, if we can just kind of reflect on that, some of us may listen and hear the hope of how to get to this place to build a more equitable and seamless system. And would love if there's folks who reflect on that, who, what brings you hope in this vision? There may be many realists among us, and may list and identify barriers to achieve the vision. And so if we can look at it from both kind of the hopeful place as well as the reality, wonder if you also identify some barriers on where the work remains. Any thoughts there?
So this is Lauren. I was trying to bite my tongue and let others jump in first, but I'll go first. That sentence about relationships matter is the piece around this whole process that really gives me hope. And I actually have, I don't know if you could all see this, but I have my notes. This is actually from some language from the Help Me Grow National Center, and you can see that crew has clearly gotten to those. But I keep this with me, and there's some really great language that came out through the National Center around early detection, developmental promotion, and connection to supports and services. And I think there's a piece in there that I think that we're getting at with our vision, but I want to be really explicit about it, in that this whole process is not just about the screening, right? It's about the promotion, the early detection, and connection to supports and services, but in a way that is meaningful to both families and providers. And that what we offer as kind of, caregivers, healers, early educators, that what we offer is driven by families' priorities, their kind of, psychological and cognitive readiness at that time, their interests, what they want, rather than sometimes what we think that they need. And that it is always, consistent with their cultural preferences and linguistic preferences. So I think we're getting there with that. And that's the part that excites me, is that really kind of being explicit about the fact that this is gray, right? It's not black and white. It's not just about kind of checking off a screening or asking the 2 questions on the hunger vital signs. This is about true family engagement. And it's something that I think, again, Vermont does really, really well. And so I think we need to elevate that and really be explicit about it in our vision, which I think we're all on the same page, and I think we're getting there, but I wonder if we could actually be even more concrete about the fact that this is really about relationships.
Thanks, Lauren. Any other reflections on your hopefulness to achieve this vision, or the barriers and where we still need to do work?
I am really both hopeful, and I see a lot of potential barriers in this. In the beginning of the second paragraph, when screening practices are normalized and universal, less people fall between the cracks, bias is limited, and the conversations are destigmatized. I think a lot about checklists and how we think as experts that we know best and we don't need to follow protocols necessarily, even though we might recognize that they are best practices. We think we can see if somebody's hungry or suffering from depression, or that they answered that at the last appointment, so we don't need to ask that again. And part of being able to destigmatize this is having that very routine, integrated, asking these questions every time, because it might take 4 or 5 times to ask this question before somebody feels comfortable saying yes. And I think that getting out of the we know best mindset as professionals can be very challenging. And I think that having this and trying to really set things in place, as in integrating into workflows and having checklists and accountability is really hopeful as well.
I think for me, hi, I'm Beverly from Let's Grow Kids, having this conversation with this mix of people is what's really hopeful and encouraging. Instead of us having it in our individual silos, the fact that we're sort of having a collective conversation is what intrigues me about the possibilities of this work right in this moment in time. Is just to think a little bit about I don't know, thinking about how that experience feels across the settings for families and how we can make it feel like kind of a cohesive, coordinated, consistent experience. That doesn't mean it has to be exactly the same everywhere, because what every family needs isn't exactly the same, but that there's some maybe understanding of how it's being done in a framework that allows us to best support this work in a way that doesn't feel that feels like a good use of resources and a good way of being efficient and effective.
Which is really the goal of our committee, right? Is that we may be having these conversations in our own respective sectors, right? But coordination takes work and takes good, consistent communication. And so the hope is that by coming together, and we have been a fairly consistent group, coming together monthly. So thank you for making this making the commitment to show up monthly in this forum and in others, right? To be able to both learn and deepen our understanding about practices that are happening, as well as identifying what we can do to improve them, right? And there's been follow-up between meetings, which is really cool. And so today's work, we kind of want to continue to deepen that when we're talking about those intersections with pediatric practices. And so if I can just transition us, this is goal 1. You've seen this slide before, but when we're talking about the Vermont Early Childhood Action Plan in goal 1, we're talking about all children have a healthy start. Healthy development depends on early experiences, their environment, and the health and well-being of their parents and caregivers. This is what we're talking about, right? And so this has been the charge of this not so new team anymore. The Child Outcomes Accountability Team is to improve integration and coordination of early childhood public and private partnerships committed to the health and well-being of children and their families. The group will inform strategies and monitor progress to ensure that children are healthy, thriving, and developmentally on track from prenatal period to third grade by promoting and monitoring outcomes in the following domains: physical health, developmental and educational outcomes, mental health, and basic needs. Goal 1 also promotes the importance of prevention and early identification across the same domains. So just want to remind folks that that is our charge. And this is the images that we often see around the nested circles. So Brina, I'm going to hand this to you. I asked Brina to kind of give us some grounding around the data. How are we doing with child outcomes in Vermont? And what does the early childhood system need to understand about health systems? And what are high-performing medical homes and different care coordination models? And then we'll have a discussion about how we can improve the collaboration, particularly thinking about the impact of the pandemic and what we've learned. I think there's some stronger partnerships from that, but also greater needs. So I'm going to hand this over to Brina.
Thanks, everyone. You want me to do next slide, Beth? Next slide, please. Okay, so Beth already, well, I think everyone knows me. I just put it in the chat that I did make a transition in the fall that wasn't very well timed with the pandemic, but I'm at the Vermont Child Health Improvement Program now as senior faculty, but it was too early to abandon the health department, so I stayed on as they call me the physician advisor, but my primary role is the school and child care branch in the Health Operations Center. And I wanted to just echo the agenda that Beth already put forth, but we want to look at what's in the Early Childhood Action Plan quickly. I want to just everyone come away today with a little bit deeper understanding of the pediatric healthcare system in Vermont. I know you know a lot about it. I want to introduce or reinforce a new and exciting concept called the high performing medical home, and then end with trying to get a little bit of a handle on what's currently going on and where we want to go. Next slide, please. So these are the indicators right out of the gate. I did want to make the observation that it's okay for communication power to call something physical health and then have a different category of mental health and a different category for developmental outcomes, which is necessary when you're trying to quantify, but that's a bit of an artificial construct, right? So physical health is not the only thing addressed in a pediatric career or in a pediatric office. In fact, I would argue that it's very little about physical health in the prevention space. If you look at the field of pediatrics, it has its roots in family systems, education, and really social work. They do some cool studies of sort of people's pathways into that field, and it's a nice kind of integration of many of the things your backgrounds and also the things that we care about as a state. So we're grateful that we remember pregnancy in the Early Childhood Action Plan. We do have a bit of a mission together to get more of our early childhood systems work to think about pregnancy. It is, we have the best prenatal care in the country. We get 86% of women in the first trimester, which is so astounding that we don't get much grant funding for pregnancy care because we somehow crack the nut of at least acknowledging, getting people to know they're pregnant and into their medical providers. That has something to do with Medicaid policy and coverage. It also has to do with our workforce being robust and welcoming. We also have the best rate of well child care in the country, which mirrors the pregnancy experience as it relates to Medicaid coverage, but we also have extraordinary physicians and nurse practitioners and physician's assistants who commit to this prevention work. We have the highest rate of health insurance coverage in the country. I always want to note in health insurance, I know you know this, that there's a concept called underinsured, which means you can have health insurance, but it could be catastrophic coverage or you have an extremely high deductible. So this metric alone is artificial when you think about the impact of healthcare costs on our families. We have above average dental care, but we're not in the top percentile for getting our youngest children into dental care. We have the right public policy about this. We have excellent Medicaid coverage, but we have a disconnect in that early in my career, the recommendation was children start at age 3. It shifted to age 1, but the workforce of dentists weren't trained in infant and toddler dental care. So it's been a lot of work to try to increase the comfort and the capacity of our dental system to take 1-year-olds. That being said, pediatric dentistry is amazing, but that's regional and not available to all Vermonters. Home visiting is near and dear to all of us. It is one of the best research bases in our country, 30 years of understanding why that type of service provision is so important to our families, and yet I worked my entire decade in MCH to try to get more money, and I was not successful. And Reva Murphy and I laugh about it, that the minute we both left, it appears there is going to be an investment in home visiting this year. So that feels really good, and we'd like to think it was some of those efforts. And then our breastfeeding rates are excellent. I didn't bring all the numbers because I have to go quickly today, but we have very high initiation rates, but we have a pretty low ability. We are only in the 20% range when we get to 6 months, and that's entirely predicated on our policies around return to work and our workplace support of women who are breastfeeding. Next slide, please. And then when you're looking on the longer range, all of the work we do in pregnancy has its impacts on the health of the pregnancy, the health of the baby, whether a baby's born on time or a baby is born at a healthy birth weight. These are also metrics that we are in the, top. We get an A from the March of Dimes every year from this. But I think when we were planning this out together, we worked hard to not put prematurity, because that's not the goal, because we do so well in getting babies born on time. It's the idea that a baby was born at a healthy weight, and there are so many social factors that contribute to a baby's birth weight. So this is a place for us to ground our social determinant conversations. Vaccine rates are excellent. I'm super curious to see what happens as we recover from COVID. Just a little shout out to the pediatric community, figured out a way to get kids vaccinated even when we weren't doing in-person visits in healthcare in March, April, and May. And so I'm looking forward to the qualitative to match the quantitative. We don't have the full analysis of the 2020 vaccine rates for our children around the country. There's deep concern about this, but I'm holding my breath that in Vermont, it will be that with all that creativity and vaccinating children in the trunks of their cars, that we will find that we didn't have a big slip. We could spend this entire talk talking about the growing concern about the weight of children and the physical inactivity, the poor diet, and the concerns that we have around the connection between mental health and eating habits and sedentary life. So that's a big bucket for the next decade as we recover from COVID. And also, we're never really going to stop our attention to substance use in pregnancy, because we have two really glaring indicators that we have not cracked. We have the highest rate of drinking alcohol in pregnancy in the country, and we're in the top 3 for tobacco use in pregnancy. So when you think about substances, many of you have been around a long time and know Vermont leads the way in the honest and family-centric conversation about heroin use and opiate use in pregnancy, but we have dropped the ball on somehow normalizing or turning away from addressing alcohol and tobacco use. Next slide. And then I pulled out, these are not under the physical health, but I couldn't help myself. The developmental health of children is squarely in the healthcare system as well as the public health system. And I don't have these numbers up to date, but this is another sort of proud moment of the COVID, which is in our efforts to screen all children and the collaborative partnership between child care providers, home visitors, and our medical field, we were able to quickly pivot in COVID and get our amazing contact center, Help Me Grow, Elizabeth Gilman, to help providers do this virtually. So silver lining of COVID, the online ASQ access and engagement of our especially healthcare professionals increased during COVID, and we're never going to let that back down, because it was a hard sell pre-COVID because there was an ownership feeling that the docs wanted to do the screen in their office. I think we've now pretty easily demonstrated that there's still great relationship opportunity in the office, but if the screen itself is done on an online system, it is better for everyone. Next slide. Okay, I'm going to blow through this because I think you all know this, but I like to ground us in the notion that we have the best pediatric healthcare system in the country. And that's not self-promoting, because I haven't seen a patient since 2009. This is a history that I'm very proud of, but probably the cornerstone of the history is that when the Maternal and Child Health Bureau and the American Academy of Pediatrics wondered about a preventive service guideline that they could standardize for the country, they ultimately landed with Vermont editors. And if you think about the population of children in Vermont compared to the rest of this country, that's an incredible experience. So this is the 4th edition that we're working from currently, which came out in March of 2017. And it was, the history of pediatric healthcare is fun and interesting in that early on there were a lot of guidelines about physical health and what's called anticipatory guidance, which is what are the topic of interest to families that need to be addressed at each visit. The third edition in 2008 was the first time it said in the guideline, you need a validated developmental screen at 9, 18, and 30 months. So prior to that, and I was part of this, you would just sometimes do a Denver developmental screen, but sometimes just ask a family, did you have any concerns about your child's development? Is he walking? Is he talking? It's very funny to think back. So that was the third edition. The fourth edition, because of our beloved Paula Duncan and a lot of national work to think about the venue of a health visit, to think about the social construct of a family's life, it was the first time the guidelines were required, really recommended / required, that you address social determinants in pediatric healthcare visits. And the chapter that Paula wrote that's in the front of this is so beautiful, and I'll share it with you as a PDF because it's exactly what Beth shared at the beginning of this meeting, and I actually got goosebumps because I love alignment. So somewhere in the range of 95% of infants get the right amount of well child care in the first 15 months. That's that metric. I would go even further to say that we're getting in the 98% of kids are coming in the first week. So the opportunities are there. I do want to make sure people, to speak about stigma and to understand how much we want this to be universal. Your health setting is the perfect place to address the social determinants of health, because it is, it's been studied extensively that it's a social good to bring your kid to the doctor. You know, you can be having a very difficult day, a very difficult week, with lots of things going on, but if you can organize yourself enough to get in for that checkup, it's a really important milestone that you've achieved that week, and that means that platform we should be utilizing it extensively and universally. And then I'm grateful there are studies that show that people actually trust healthcare. Let's hope that doesn't shift over time, but currently that is the truth, that there's a high level of trust with families. Next slide, please. So many of you were here, but I like the origin story of when we were getting organized about the integration of human service and healthcare. When that fourth edition came out, we decided we needed to take it on the road, because we knew that pediatricians were not going to feel comfortable screening for social determinants without help, bridges, and resource connectivity, because it's actually unethical to screen, even if it's universal, and then leave families without adequate resources to address what you find. So we hit the road. The American Academy of Pediatrics paid for the most delicious dinners. I will vote that the one at Queechee at the Simon Pierce remains like, when I get hungry, I remember that meal. It ended up being 264 of you. The human service community came out in droves to meet these 48 healthcare providers. It was mostly pediatricians, some family medicine, that came to say, if we're going to screen, who's going to help us? And so the theme that really emerged, which was at the beginning of us really being able to start to amplify the Dulce model, was that it's the right venue, the pediatric medical home, to screen, but we need to create care coordination models that will be authentically connecting families and working together, as Lauren pointed out, to meet what families want to do about their current sort of objective challenges from the screen. Next slide, please. So then just last year, parallel tracks that we keep track of, because we have some leaders in our state like Kay Johnson, who's a maternal and child health leader for 30 years, but she's also very connected to the human service field. So this esteemed group of 8 organizations got together. You'll note there are no healthcare, delivery. There aren't pediatricians on this group, but they were starting to pull together in the idea that we have to transform pediatric healthcare in order to meet the needs of young children, especially in the Medicaid program. Next slide. So they came up with the term high-performing medical home, which built on the notion that a medical home is a term from the 1960s that was coined in the pediatric field, which was for children with special health needs. So when there were complex health needs for children in the 60s, you had to have a hub. There was so little children's specialty, and the medical centers were not, you know, creating teams around some of the really rare conditions that were affecting children. So the medical home became an idea that you needed a 24/7, culturally competent, you know, hub for your child's coordination. And then that term got picked up by the adult community. It's now used extensively in our health reform efforts, like the Blueprint and OneCare. And so the high performing, it's not Medicaid, it's medical homes in Medicaid. I had never noticed that typo till today. Is this idea that on the left side, we already have this in Vermont. This is where you actually have a comprehensive approach to well visits. I will acknowledge for all of you that have your own children or have been in these settings, there are physicians who just check up on kids by patting them on the head. Is everything good? You know, and that's not what we're talking about. So we always have to put our own experience a little bit off to the side when we're thinking about systems, because a comprehensive well child visit is actually quite organized around Bright Futures, and there's a schedule. And interestingly, Medicaid programs adopt Bright Futures as the standard for Medicaid. So in Vermont, you can't be a Medicaid provider or be reimbursed by Medicaid unless you follow Bright Futures. So we're very lucky about that. So we know our offices do the things on the left side. We know many of them are in the middle bucket here. They're trying to figure out care coordination. I don't like case management, just that's a breed of bias. The people are not cases. So the coordination of care is where all of the last 10 years we've been grappling with, and that's the Blueprint, community health teams, it's our mental health agencies working in practices, it's trying to get, you know, who are the early childhood people that are well known to the pediatrician so they can call them, linkages. And then on the final piece, as you head toward the right of this diagram, this is where we really nail it with models, measurement, training, and a much more quantitative approach to the integration of services. So that's the aspiration. Next slide. So what we're seeking clarity on always, and we really need your help, is now that if I've made the case adequately that pediatricians have a role and we should be spending more time with them, then the fun work at the community level is who's screening, what are the tools, and then how do you match professionals, meaning all of you and the people you work with the type of care coordination you're seeking. And for simplification, we've started to talk about it 3 ways. If it doesn't resonate, I'm happy to keep pivoting. But from a pediatric perspective, we think about the universal support, and that is absolutely key to the pediatric healthcare system. And I loved what Beth and Lauren and others were saying. We cannot make assumptions about who needs what. That's a really big trap, and I would argue that we've been in that trap for a long time. Universality. Then we have a group of young people and families who are experiencing developmental concerns, mental health challenges, and they need system navigation, and that might be a subset. This is sort of a hypothesis for your thinking, our thinking. And then there's the traditional, this is the root of medical home, is children and families experiencing complex medical conditions. What does that care coordination look like? Next slide. Okay, so I tried the old, the pitfall of you try to make a comprehensive slide and the minute you do it, someone's going to not see themselves on this slide. So this slide should have said, we'll go back one if we can. That slide should say a snapshot of some of the efforts. So as far as I can quantify, let me stop here for a second and say, Chris Pellegrino is here today, and maybe you don't know her as much as you know each other. So the bedrock of the Vermont Child Health Improvement Program is a longitudinal quality improvement network of pediatric and family medicine providers called CHAMP, which stands for Child Health Advances Measured in Practice. And the CHAMP network was developed because VCHIP had been doing quality improvement for a decade or more, where they did one project, tried to get everyone to do something like developmental screen, and then left it. And the question was posed, is there sustained quality improvement when you do a project? The network was created, and we have a focused project every year with the network on a topic of interest to primary care. This year, they picked high-performing medical home. And, you know, it sort of aligned beautifully with CHAMP. So I wanted you to know that's why Chris is here today. There's a lot more to say there. So in the efforts we're doing with the high-performing medical home and other projects at VCHIP, we're noting that there are a lot of efforts. We have a lot of human service colleagues trying and succeeding in working with pediatricians. So we want to amplify, not create. So here we have the DAs, our friends at the Blueprint, OneCare. The health department has medical social workers. There's a lot of effort to figure out what's the best role for them. Parent-child centers have come into the game beautifully as family specialists in Dulce in 5 communities in Vermont. And we also have the system around these efforts, which is our incredible childcare providers, early care and learning. We've got Help Me Grow. We have our CIS system. And I always throw WIC in because there's something powerful about COVID and nutrition. And I know this group has some of its roots deeply in that basic need. Next slide. Almost done, Beth, I promise. Okay, so here's where we are. This is where we are with the VCHIP project, and I want to head into the conversation part. So I just wanted to reassure you that we have ongoing efforts that we're going to have these high-functioning medical homes for our patients and our families, and what they're accessible, family-centered, continuous, comprehensive, coordinated, compassionate, and culturally effective. Then I want to remind you that a well child visit, which is 26 minutes, it's actually about 15 by the time the child is weighed and measured. Health promotion, disease prevention, disease detection, and then this big bucket of what we call anticipatory guidance. So partnering with medical homes is valuable. And I took this right from a CSSP, the Center for Study of Social Policy brief during COVID about the Dulce approach. We've got ourselves a triple crisis with families. It's not just COVID. It's the economic issues surrounding a pandemic and the social justice issues of equity with this disease. So I don't know if something got cut off at the bottom, but what we're hoping people feel is that now more than ever, your pediatric environment is a place to address everything that families are experiencing. Next slide. Oh, I made it. How'd I do, Beth?
You did great.
9:41. Okay. I do want to say one more thing before we go into the conversation, because I will always be your champion for your pediatric colleagues because it's such an incredible group in Vermont. And so over the weekend, as we continue the conversation about opening schools and getting a better handle on what just happened to children and families in this pandemic, we surveyed the pediatricians. And I was a little bit negative on Friday afternoon. It took us till Friday to get the survey right. And Friday afternoons are not a good time to send out a survey. But in one day, we got 41 responses, and there were only 90 pediatricians in Vermont. And the 41 responses were paragraph upon paragraph describing what they're seeing, what they're hearing, what the experience of being a pediatric healthcare provider is in the context of children's mental health. And we've amplified it now. We've packaged it up. We gave it to the governor last night. They're going to talk about it on the press conference tomorrow. So you have a workforce that's in this with you, and I'm really, the more bridges, the better. So I'm excited for the discussion. I'll stop there.
Thank you. So I will invite folks to, I stopped the screen share so we can see each other. And I put the same question that was on the slide in the chat bar, which is kind of as we keep talking about COVID recovery. I don't think we're quite there yet, as my children are certainly home and I'm still working from home and they're still interrupting, right? So whatever recovery looks like and whenever it arrives, hallelujah. But how can we improve collaboration among pediatric medical homes and community agencies to strengthen families and improve care delivery? So would invite observations about what Brina shared, as well as observations about where we need to lean in to improve the coordination.
I'll pipe in here. So I loved the pediatric grand rounds that several of us here on this meeting helped dream up, and it did launch in a virtual capacity. So I'm hopeful that that will, I think the intention was that that will be an annual occurrence. So just knowing that perhaps that's, you know, in the picture for the future. So bringing our tables to a setting like that, I think is really helpful, where pediatricians feel comfortable, they know what to expect from a grand rounds. You invite, you know, national speakers. There's something to be said there. So having a big event, but on an ongoing basis, how do we connect with the medical field through our council networks is something that I think I'm hopeful that some of you have some tips on how I can explore that relationship building piece.
Yeah, that's a great comment, Amanda, like how we can think about how to explore those connections, but I can't have this conversation. Like, I think Amanda's right, like the grand rounds, you know, prove successful. I sort of want Brina, I want this to also go to early care providers, right? Because we invited them to that, we got great participation. But I almost think that if that were to happen again, before that happens, it seems like a, you know, forum or workshop, something for early childhood providers. I would love to hear what Brina just presented, basically flipped to the early childhood audience so that they could hear and really know what's going on in pediatric offices and those efforts. And then I would love to have that combined with, you know, what's going on with Help Me Grow and the early childhood screening efforts, right? Because there could be a really powerful, informative session there too. And then, you know, it's sort of Let's Grow Kids style, right? The call to action for something like that would be, please join grand rounds, right? And they would go in so much more informed about the bigger picture of what's going on, as well as some things that they could do in their own programs to better collaborate around, you know, the screening. And yeah, I'll stop there.
I'm going to pick up
Beth,
on what Tanya said.
Oh.
Sorry, Brina. I was just going to pick up on what Tanya. I was going to pick up on what Tanya said, and that piece of a continued reach out and effort, because I think, you know, Lauren's project through VCHIP and my project through VCHIP, and then, you know, like I had all the providers come and talk about STARS and Help Me Grow and, you know, the ages and stages a year ago, and now they're all like, we don't know about this. Like, is this new? So we're looking at a high percentage of turnover. Plus in early ed, I'm looking at Linda in the corner of the screen. The brains are so full and so actively doing so many other things that, well, this is really important, it gets lost because it's not a use in the moment oftentimes.
I was just going to do the chat. You know, I'm becoming, I don't know if any of you know about the noon calls that we've done since March. We've done 164 phone calls since March 18th. And I'm often the person that's supposed to do the chat box. So I'm very distracted, but also I love chat boxes because I think it gives people, it adds like a richness to conversation. So I want to note Charlotte's on. Hi, Charlotte. And she has this awesome 4-word response to Beth's prompt. We can ask families. that should be the name of this talk. And then Sheila amplified it by saying, why don't we bring this forth to parents? So I did want to note, you know, I'm trying hard. I'm so glad Scott's here, but I could talk about Dulce all day, like 8 times to Wednesday or whatever that expression is. But I've learned to talk about a broader context. There are a lot of ways to coordinate care and to think about Vermont's families. Dulce has families in the center better than any model I've seen in my career. And it's because the family partners are at they sit with the group and do the, you know, the kind of systems work of Dulce, as well as being able to talk about the experience if they themselves had been the client, or not the client, but had been in the Dulce model. So Scott, do you want to speak to that piece so the group can, because we have a lot to learn from Dulce. We can't promise Dulce for everyone, which is the problem with limited resources, which is why I've dialed it back a little in my rhetoric that it's the solution to all, because nobody's following that with cash yet, except for One Care. Go ahead, Scott.
Thanks, Brina. And I will also say, and the health department. You know, what I was going to say in terms of the question at hand, which is how do we continue to engage pediatrics in a way that's meaningful? My experience with Dulce, going back to 2015 when we first launched the first site in Vermont at the Lamoille Family Center, was I knew that there was a gap, a real gap between what we in the human services system, in my case, Parent-Child Center, had to offer to be able to address health-related social needs with the healthcare system, and specifically in pediatrics, because it was so way up front. And so in every effort that we had put forward, no doors were opening. And so I finally decided that we needed to find some money to be able to put on the table to hire somebody to bring into the healthcare system. And that's what allowed us to truly integrate a human service employee, in this case, a Parent-Child Center employee, into the pediatric office full-time as part of the team. And so what I was going to say in response to the question was, we have to have something to offer. And I believe it truly needs to be a formal and high level of integration, which I think Dulce has been. Not only is it a Parent-Child Center family specialist, but it's also a member from Vermont Legal Aid. So a lawyer's at the table on a weekly basis with case reviews, as well as other early childhood personnel. And so it's a pretty intensive group of people and a pretty disruptive model. I think that all pediatricians who've been involved would say from the beginning, but within a month or 2 or 3, they all say, this is amazing how much it's improved my capacity to address health-related needs for my patients. It's just amazing. And it's universal. I think everyone knows that everyone in a pediatric practice, every family that has a newborn is offered Dulce. And 96% of families accept the Dulce approach and engagement with that whole team. And then the last thing I'll say is that, not unlike Brina's comment before about it's taken 10 years, 20 years to get an investment in home visiting, we are so woefully short of true primary prevention and pediatrics investments where we can make investments that help us force a level of integration and deliver a much better product to families, young families with children. So, you know, on the advent of the day when they're talking about 1115B waivers and legislatures in session, we have to continue to have a strong voice to make sure that those investments are made.
Does it resonate with you all I'm seeing the chat too, that Janet's here just wanting to amplify the connection between Dulce and Help Me Grow. I couldn't agree more. And then Charlotte is working on the improving care coordination for children and youth with special health needs. So I'm curious if that notion that we have a ton of work to do universally, Dulce is one model. We have a ton of work to do with care coordination of families with developmental concerns and mental health challenges. And we have a ton of work to do in children with special health needs. Is that artificial? Does that feel like, Because what happens is, I think the people that do the work bump into each other a little bit sometimes. There's a little, I would never say we have enough resource, but there is a little bit of a, who among us in a community or in a practice is working with which family. I'm just curious how to organize that a little bit better.
Rena, when I saw that construct, I appreciate a good framework. Love that. And I love the idea that, we need to sort of look at sort of some categories and care coordination models for different categories of needs, or level of needs would be different. I think that makes great sense. I was curious about where people with maybe not developmental or with complex medical needs, but maybe complex social needs fit that construct.
Yeah, I hear you. It's also that folks with developmental concerns or children with special health needs also have social needs. Like it's a Venn diagram. But when Charlotte put this in the chat, it reminded me, originally we funded our medical social workers at the health department to work with the system navigation of the sickest kid, the kids that had trachs and were in wheelchair. It was a very I can't get the pulmonologist to talk to the neuromuscular doctor. It was very specific. But most pediatricians have asked us over the year, can we please use Kelsey to help us navigate the mental health system? And when a kid comes back from seeing Jim Hujak's team to a community where there is inadequate resource for the treatment plan, right? The academic medical center says this child needs 25 hours of applied behavioral analysis, and there's no one to do that. They wanted the medical home to pick that up and at least coordinate the care in that system. So I'd like to make that pivot, and then Charlotte and I would argue with each other maybe to say, well, that's a bummer, because now the kids with multi-system physical complexity don't have that resource. So I think it's okay to name it if people are struggling in a practice. They've got I like to promote a model that you know who your people are as the care coordinators, and then you could work it out in a community level of how do you want it to work. And we do have a model of this with Dulce in the southern part of the state. At Mount Scottney, they didn't have enough babies to support a full-time family specialist to do Dulce, because you have to have, you can't, if the whole role of Dulce is to meet new babies and there's no babies on Tuesday, Thursday, Friday, what are you doing all day? Well, you're helping the babies you met on Monday, but so the volume mattered. So because they didn't have adequate volume, we built a back system where that same family specialist is care coordinating older kids, but those practices have blueprint care coordinator. And then they also had a remnant of a family wellness coach that Jim Hujak had trained in 2009. So that they have 3 humans, and they're doing very well. Wouldn't you say, Scott? They're figuring it out. Is it an age cutoff? If the babies go this direction, if you get up to toddlers, this person has more experience. So it's imperfect. I just wanted you to know that it's not easy to put on a slide.
Well, I like the notion that there were different levels, like there was sort of universal, there was complex, and then there was something in the middle. And I think my comment may have been more of a languaging one, because I know, Brina, from all the opportunity I've had to talk with you and listen to you and learn from you, is that developmental screening is often a flag for a more, it's not just, a complex set of underlying reasons for that. So for me, it might have just been a slight languaging thing, so that people who might not automatically know that or see that in that, when you say developmental screen, understand the complexity of what you're really trying to get at with that. So, that it's both behavioral, and social, with both a health and social complexity. So anyway, I did like the idea of 3 tiers.
I see Charlotte's hand, dutifully using her Zoom hand.
Well, thank you. Hi, everybody. I just wanted to say, Brina, I'm not sure I'm at a point where I would ever argue with you. I'm still learning so much from you. But, you know, I wanted to comment on, you know, some things that you've said and some things that Bev has brought up. You know, I really think that like in the disability world, there's this thought that if we create something that's accessible for like the most the people with the most barriers, then it's going to be accessible for everybody. And I think that perhaps the same rings true when we talk about care coordination. If we can talk about a way to provide, you know, care coordination that centers on the patient and the family's needs, our most complex, medically complex or socially complex patients and families, then we're going to have built a system that works for everybody. And I know that's kind of big, broad brushstrokes, but you know, if we think about it in that way, yes, there's absolutely categories. But if we talk about the families that have the most robust need for effective care coordination, then care coordination is going to sort of, then the same systems are going to kind of work for families at every level. And I also just wanted to say, I love this growth mindset that this group has, because I know, you know, I haven't been doing this work for very long, but I know folks have been working on this for years and years and years. And the fact that we're still working on making it better and working on like the systems improvement is just, rather than like getting frustrated, it feels like folks are still really interested in getting it right. And that's really inspiring. So thank you.
I'm so glad you said that, Charlotte. It's funny for me because those of you who've known me a long time, I do lose energy sometimes, which is noticeable, because there is a Groundhog Day phenomenon in some of it for me. But when I see your faces, it gets better because some of you are new, and some of you are new to a role that can actually amplify, right? So because we keep moving about, and that's it, and it's good I stepped away from the public policy, because that was you know, that like, so in the chat, Cheryl is updating us on Act 264. So Act 264 has always required these, you know, service coordination plans, and I've never saw myself in them. I never understood how I had never even heard of them when I was a pediatrician. So my great friend Cheryl and all these other wonderful human service colleagues were like, oh, okay, let's get the pediatricians into this really like landmark legislation and work that still really matters for kids. So that's a great example. That's a very concrete and seems small, but it's very big. And the other example I'll give is I'm completely obsessed with the Agency of Education these days. Kate, is Kate still on? Because I found my way in through chairing the How to Get Schools Reopened task force. And then I started to understand their language a little better. So they're working hard on recovery plans for children, for schools, I should say, to meet the needs of children and families post-COVID. And there was nothing about the pediatric healthcare providers, because it's an education plan thinking about mental health professionals who, you know, luckily we have a workforce, school-based clinicians that are physically in the building, so it was visible. So I had to push on that, and even just getting it in the plan that schools are going to think about their pediatric health community is a win in this integration conversation. So I'm trying to find the small, like Dulce and what Cheryl just said about Act 264 and the recovery plans in AOE. I'm trying to find the places where we can at least name and then follow it with action that pediatricians have a role as well. And the reason I'm a drumbeat on it is because of the access. We're just going to keep standing on the shoulders of the access from the 90s that we cover kids to 312% federal poverty in our Medicaid program. You will never, when you all move to, you know, Florida because you're cold, you will be astounded at how poor the public policies are for children in this country as it relates to health insurance and health care. So I'm just excited that we can do small, medium, and large attempts at this. And then I just want to acknowledge too that Amy's asking about, I think Amy, chat box. Yeah, Amy's asking about home visiting. I'm not the right person to ask about that because I'm way out ahead of something, but I do believe that it's public that the legislature is trying to get some more money over to the health department to coordinate the home visiting efforts that were already federally funded with that McVie money, and now there would be some state appropriation, which would be the first time outside of the, you know, when we got that federal money, our job was to get state money to go with it. And so I can't say much more about that because I've lost track of who has to approve it and whether it's real or potential. You know how this season is. I thought it was a done deal, and maybe Sheila knows better.
I do. I have a little. I have a little more information than that about it. We did meet with the parents as teachers, staff, maybe last week or the week before, I can't remember, to talk about the funding. Like, even though we have this money, apparently it doesn't fund all of the services that are delivered by the model. So we still have to work out what's covered, what isn't covered. I think one of the first steps, and I could be wrong, so don't put this in any notes or anything, but I think one of the first steps is for the Department of Health to hire a staff person with this money. So that may be one of the things that is happening now. I know Elisa is swamped, and so I'm not sure how fast that's moving, but we are moving ahead as fast as we can given these times and the other things that the health department is doing with COVID.
You know, there's a job. Someone go over and work in the health department. It's fun there.
I wonder
you
if
get to work with Janet and Lauren.
Yeah. I wonder if we can take a moment for those who have been listening in. If you want to share, what are you hearing? What themes are you hearing in terms of where we need to lean in? Any other reflections on kind of how to improve this coordinate? I think we've heard some really cool models, right? Things that we definitely want to figure out more sustainable funding to expand, and things that we have already institutionalized essentially. Any other reflections or observations from folks who are listening in?
Hey everyone, it's Renee. Can you hear me?
Yeah, Renee, go ahead.
Good morning. Thank you so much for that presentation, Brina. Always great to be in a virtual room with you and to hear what's happening. I think, Beth, for me, the theme that I heard that was really jumping out is, and I think I hopped on the call when Lauren was talking about the family engagement piece. So that's something that seems to be resonating for me, right? It's not just about the developmental screens. Like, the whole point of establishing these types of relationships and collaborations is to ultimately improve those child outcomes and support the family. So we need to further develop those mechanisms that allow us to engage families around those needs. So I'm excited about the opportunity of using, and there's my child in the background, excited about the opportunity of maybe using the BBF Families and Communities Committee to host a discussion about the intersections, between childcare and kind of social service work and pediatric homes. And then the other thing I just want to offer in terms of, models and potential strategies for making these connections within communities. The Head Start community is required to have a health services advisory board. They also have health managers on site who are responsible for overseeing, making sure that those children are getting their screenings done, their well-child exams, immunizations, all that. But the requirement to have a health advisory team has really allowed the programs to make those connections with their local pediatric providers or mental health providers, to also bring their families and parents into the room, their policy councils. And it's been a mechanism that has been particularly helpful under COVID, as programs were trying to figure out how to reopen safely, how to make sure that they were hearing families and meeting those needs. The Health Services Advisory Board really gave Head Start programs an opportunity to do that work. So, and thinking about other strategies or models that we might use. Avery, turn it down, please. And thinking about other models we might use, that's something that while it wouldn't be required, it would be easy to kind of extrapolate that out if programs were interested in building those connections. And of course, it could and would include CIS folks. So I just wanted to offer that up on the table as we were thinking about strategies to increase this kind of collaboration.
That's great, Renee. Can you say the name of those councils again?
I think they're health advisory team. Yeah.
Renee, I wrote it down. Well, first of all, a couple things. Head Start has always understood the importance of pediatric health care. So like that is a model. So one of the disconnects, now that I'm not in public policy anymore, I'm going to say something. There is a disconnect in Vermont that we have the best pediatric healthcare system in the country, but we don't use state funding for Head Start, except, a pittance. So
yes, Brina, yes, preaching to the choir.
Yeah, right. So I could say stuff now. Kind of fun. So what I like about this conversation, though, I've always wanted to use the Head Start model in the rest of our early childhood system work, but I haven't figured out a way to leverage that. And I think I think an action step here is that the health advisory team and the BBF regional coordinators understand each other a little bit better and see what could go on there. Because as Beth, we work a lot with BBF coordinators to get health to the table. It's not easy to get a pediatrician to come over at noon or at 2:30 so we're always looking for those partnerships. I'm sure Amanda would agree that COVID is helping this because the pediatricians lifted their heads up and said, I need school nurses, because COVID is all about COVID coordinator, school nurse, medical home. Can the kid go back to school? What about childcare? So there's been this team-based care that has come out of this terrible time. And I think a health advisory team, if a BBF coordinator knew who came to that, and there could be like even just taking the minutes and putting them forth into the rest of the council, or a lot of ideas there. So, and we should play a game at the beginning of meetings. Raise your hand if you worked for Head Start, because Chris Pellegrino did, and I think Sheila did, and I did, and my mom did. So raise your hand. So Head Start. That's a great action step.
Tanya, Linda, that's awesome. Sheila.
Tanya did. It's like an origin story, like Scott. I think Scott left, but the only reason Scott and I are friends now is because of Paula Duncan. So the whole thing is like, there aren't that many entities in Vermont. So if Head Start's doing something well in the health sector, amplify it. I've used that word 9 times this morning. I didn't even plan that.
Yeah, Brina, I agree. And I think it could be kind of a bi-directional relationship, right? If we could loop BBF regional coordinators into health services advisory teams, or someone from the council as a member of the Head Start team. And then, oftentimes Head Starts are there at BBF regional councils, but maybe it's more about making sure that their health manager gets to a few, if there's a specific topic around health, or I think there's a way to plant people within both systems so that kind of integration happens. The last thing I'll toss out in terms of theme that I heard was just around substance misuse. Brina, as you're talking, it's like Vermont is so far ahead of the nation in all of these great areas. And yet we're, I think you said third in terms of smoking during pregnancy, and maybe third or second or first even in terms of alcohol consumption during pregnancy. Yeah. So yeah, I mean, that's kind of staggering to me. And so I think there's also an opportunity as we're thinking about these connections to incorporate substance misuse. And I'll just, put a plug in. We did the Train the Trainer event 2 weeks ago for supporting children and families impacted by substance misuse. We had about 50 or 60 participants who are now trained on that curriculum from the National Center on Early Childhood Health and Wellness. So we've got those folks in communities. We have Head Start grantees who have regional teams. I know Amanda in Chittenden is on the CVOEO team, who have action plans, related to, they've identified what the barriers and the challenges they're facing and their families are facing around substance misuse, and how to kind of mitigate those barriers and support families. So that work is happening, and there's also an opportunity to make that connection, because those figures in terms of substance misuse, those hit me pretty heavy this morning.
And I can say that we've talked about that being the focus of our meeting next month. So if you have thoughts on that, let me know. But Amanda, on our team, we've had some UVMMC funds to pilot an effort around substance use disorder and trying to integrate early care and substance use treatment systems. So we'll talk more about that next week.
I'd love to help frame that a little. Or, there's a concept in public health about you can't do a campaign about all substances because so they actually, I'll just back up to say they've done some really interesting research about people who are obese and smoke. And then there's a group that smoke and they say, well, at least I'm not obese. And then the group is obese, but at least I don't smoke. And you lose audiences for the public health messaging if you're too comprehensive in your approach. So you probably have to just call out tobacco and alcohol. When you say substance use, it becomes, a lot of people go straight to opiates, which is okay. But, I make this argument in every meeting. We have a really solid system of care for people who are using opiates. It doesn't mean it's not a crisis and that we don't have to keep working, but it's that alcohol, and then tobacco has a really important, I'm sorry, Cheryl left because the data for our families about tobacco is the same families experiencing mental health challenges. So it's just a funny thing to try to grapple with. But I like doing alcohol all by itself because the demographics are different and it's not a group of people that we're used to messaging. It's middle class people who think drinking's okay, and it's normalized by our healthcare colleagues. So I'll get that out early. So if you're going to do substances, Beth, let's think a little bit more about how you want to talk about it so it doesn't overwhelm people, the weight of it, as all problems do.
Great. Great observations. And any other observations about our conversation or themes before we move on, if there's other announcements and sharing?
It's Linda from Addison County, and I'll just say that I think, that connection is so important between all the different providers, and we're lucky in Addison County. Brina has joined our directors network several times during the COVID, which has been awesome. And but also Dr. Jody Brakely is very active in our director network, and that's where that kind of this work has landed in our director network with a connection to BBF, but not necessarily at the BBF Council. And so Dr. Brakely has connected us with the local peds, and we actually, in January, we went to their 7 a.m. meeting, which was a little stretch for most of us, but so to start that relationship building. And since that meeting, Dr. Brakely has taken some other questions and concerns that have popped up for us to the peds, and we've gotten some helpful responses. So that relationship building is so important. And I think COVID has just highlighted how important it is as we're trying to navigate all these tricky health symptoms. The public schools have an advantage because they have a nurse, and I think it's really kind of easy and natural for the nurses to call the doctors or the doctors to call the schools and talk to the nurses, to where us, it's it's us directors who have to make those calls, which feels a little less comfortable and can be really challenging conversations sometimes. And even though there's all this guidance and we're all supposed to be on the same page, it still at times feels like we might be in the same book, but definitely in different chapters. And it's really hard to navigate and to help families understand. And, when the peds are saying one thing, but you're saying no, like you can't come back, it just puts everybody in this really hard place. So I think relationship building is key.
Totally. So, hi, Linda, Addison County friend. I have always wished for a model that I wonder if, so in that collaborative meeting that Jody's help. So Jody's the care coordinator of the care coordinator. That's pretty funny. Like, you do need a ton of warm bodies to do this. Wouldn't it be a cool world if there was someone in the pediatric office that was your early childhood liaison? Like, so the example in my practice when I was at Middlebury was, we only had one nurse who knew how to do the pap smear, right? Like, I was an adolescent doc, so I had the person that knew, because that's a complex thing to set the tray up with the speculum and everything. You couldn't just have anyone do that. So she ended up then becoming kind of the expert in adolescent mental health crises. And folks that had, like, when the Monday morning call that Johnny was drunk at the dance, it was Deb Deering. Like, we always had Deb do that at the team. Then we had a nurse who was unbelievable at asthma management. She knew how to do the MDI treatment. So why aren't we now growing, understanding that we're finally acknowledging there's a lot more going on with families than the asthma MDI? I just wish there was a gal you could call. When you call over to Middlebury Pediatrics, it's Linda calling, and they're like, "Oh, let me get Fran. I'll be right back." And
That
it's
would
not
be
like
awesome.
it's perfect because, well, exactly. But why don't you propose it, Linda? Like, your team should say, "Gosh, childcare is complex. You know, taking care of kids in this setting. There's a lot going on developmentally and with COVID and with illness. And can I have a point of contact over there, one of your care coordinators that we can bring along in the journey?" We had a nurse who was really good at suturing, you know, holding a kid down when he had to put stitches in his chin. We had a nurse. I'm old now and I'm starting to act like I just feel like someone needs to slow down and name all the care coordinators, because there's several of them. And I should have said at the beginning, by the way, I just started saying nurses, but I shouldn't have. The background doesn't matter. It used to matter. You know, we used to say we need nurses to do the medically complex kids. And Dulce has no background requirement. I hope that isn't jarring to my social worker friends on the call. Those people are just good people with training. So it doesn't have to be the medical offices loaded up with people that are early childhood experts. It's just that they are willing to be curious, to listen, and to be available. So far we're going to do Head Start, and we're going to try to have community partner meetings about who in the office will answer the call. So you're not getting a different answer depending on the provider, the front staff.
The only thing that I would just add is Brina had mentioned earlier about the CHAMP project this year being on high performing medical homes. We are going to extend, that's going to be a 2-year project. So we will be continuing along that path next year as well. We often do one focus and then move on to another. And so just so you know that, so this timing is all perfect. We're moving into those next levels in terms of care coordination. Lots of stuff we'll be moving into, but just wanted to mention that to all of you. We will be extending it out to the pediatric practices, and this discussion around integration and coordination is so incredibly important. And so great to see all of you and those who left and those who weren't able to come, and we will be working on all of that with you as well.
Thanks, Chris.
I just want to add one thought, which is, you know, we all see how COVID itself has increased collaboration, and to use that word myself, amplified the need for it. And so to the degree that we can continue to intentionally focus on the gains we've made and identify, just like we just kind of did, like when you said, you should propose that, you know, kind of just do that deeper, I hate this phrase, I don't know why I'm saying it, deeper dive, you know, dig deeper, whatever, you know, to say what would be what are some ideas, you know, how can we do our rapid cycle improvement, right? You know, what are some ideas that we can try? But be really intentional, keep like making that list and focusing in groups like this. That's what's in my brain at the moment.
And we've certainly heard some of those things as we've talked, right? Like Linda, like being one of the last ones, sort of like what's going on in Addison and how good that group is about getting people to their table and opening conversations and not being afraid to, you know, put their toe in the water to make a relationship with like someone like Jody, right? And what's come out of that. That's really powerful. And I see things that they do in that Addison director group. And I have often thought to myself, all the director groups should be doing this, right? So like, how do we share that, right? So then that kind of, to me, translate to some of the comments about how can we better use those BBF councils, right? How does, you know, this group in Addison that's so well connected as directors, they are connected to their council, they're really well connected. You know, how do we, you know, tell that story in other places, right? Because I can see, you know, I also work with a Chittenden director group, and I could see them sort of grabbing right a hold of some of these ideas that they've done in Addison and going with it, right? So how do we share that? How do we use the councils and these things to just help push this word out? Part of it's just this word of mouth thinking. But then, of course, you know, as a group, be more intentional. But, you know, I think we've heard some really good ideas in this conversation, and also just the idea of models. Well, we've heard a lot of good models in this conversation. And I know that Beth is taking notes, but I think part of the charge of this committee is we now should have this list of models that we're using to spring from our conversations and say things like, oh, well, how can we promote what they're doing in Addison? Because they're really smart, right? Isn't that part of our
and what are the components,
right?
like, oh, sorry. I think the, you know, this is all now because I'm at VCHIP, so forgive the like structure, but one of the primary things we learned in all the VCHIP quality improvement work for 20 years is it's not always physicians. Office system change and relationship, you know, like I'll give the silly example of chlamydia screening. We were trying to get more kids screened for chlamydia. It turned out you had to be handed the cup by your front staff as the kid was going into the bathroom, right? Like it's not, you have the visit, the doctor says screen, it was a system thing. So what I think Jody's role in Addison is unusual. So I like promoting models, but I also don't want to hold up some standard where people don't see themselves. So if you don't have a semi-retired former primary care doc who also is a developmental behavioral pediatrician who's willing to do what Jody does, what about asking your pediatric community, do you have a care coordinator, a nurse, a mental health professional that would be willing to come to a meeting with childcare, you know? And I guess, Chris, that would be the sort of VCHIP's approach, is to say there are multiple ways to do this with the same end in mind. Like, what are you, what's your goal?
Right.
And then hearing about other models first. But what I've learned about Dulce is it's getting a little old for me to keep talking about this amazing thing where you get a family specialist who comes and meets every single new baby all day, every day, because it's only 5 practices. So I'm just careful. At the same time, I love models, but I also want to create a little bit more, lead with the goal and ask what some potential solutions are.
That's an important framing. Yeah. Because
Yeah,
in another community, it might be you don't have the doc, but do you have Head Start? Or do you, like, there's going to be, yeah, that's a good
But
point.
I like, you know, the idea that maybe community early childhood folks can lead on BBF to help with some of that coordination, because I think that that's one of the pieces that it falls through the cracks, because we don't necessarily have time on our schedules to call and track down the right person to invite to our meeting and coordinate the meeting and do all of that. And so to have somebody else who's able to do that for us is really helpful.
Great ideas. And we, and I think it's very wise, right, for us to not fall in love with one particular thing, given our funding challenges, right? That's just the reality. Yeah. But to that point, that there are, you know, probably in every community, there's one of those things, right? Whether it's a care coordinator, a BBF council or coordinator, a Head Start, a directors group, you know, right? There's, or a VDH, you know, MCH person there's, I think that's the question, is how do we continue to promote that as well? And so perhaps there's a follow-up in terms of who are the care coordinators, right? Like, do we have that list, and can there be, thoughtful connection with those folks to make sure that they're tied in. So we're coming at the end of our meeting. I want to thank folks for a really thoughtful discussion. We ran out of time for announcements, but if there's anything you want me to pass along when I send out the notes, please send it to me. We have been thinking about talking about, as I mentioned, around substance use for next month, and Brina will loop you in terms of what we were thinking, more specifically around the opiate related project. And certainly we can create some other time. And I know I see Cynthia's on the call that we talked about talking about food security and those projects that have been going on in the following month in April. So thank you all. The meeting was recorded, so if anyone, I'll send out information following up, and would love feedback on how we can make these meetings stronger.